Okay, hi everyone. Can you all hear me? Fantastic.
Yeah.
Thank you all for joining me. I'm Deborah, co-founder of Jewish Digest. I'm here this evening with Matty Fisher, who is an aspiring filmmaker. He's 17 years old and he has Crohn's disease, and he is going to be telling us all about his story. So I'm really looking forward to hearing from him. Also looking forward to hearing all of you ask some questions, anything that you like. You can ask Matty any questions about his experiences, and you can also ask Dr. Steven Mann, who's our consultant gastroenterologist here with us this evening. Hi, Dr. Mann. We are looking forward to hearing your questions to him as well. So by way of introduction, Matty's just going to show us a 1-minute preview of his documentary, and then we'll start with the questions. So over to you, Matty.
My name is Matty Fisher, and this is how my life goes on.
Hello, I'm Matty and welcome to the vlog. And
I am a bit of pain in my stomach. I thought it would restrict my life massively.
good morning guys, how's everyone doing? And welcome back to another daily vlog.
I was distraught when I found out that it did not work for me. I had to find something else.
Thank you so much, Matty. That was excellent. Really, really inspiring. Tell us a bit about what inspired you to create this documentary.
Hi everyone, I hope you can hear me all right. So I created this documentary in order to raise awareness about Crohn's and also to encourage other more people who have it to speak out. Because one thing I wish I knew when I was first diagnosed was that it's nothing to be ashamed of, that you should be fine just to tell whoever you should want and everyone will support you in it. So that is why I created the documentary.
So going back to when you were first diagnosed, it was what, 3.5 years ago. How did you know, what were your symptoms then? How did you feel at the time? What made you aware that there might be something wrong?
So almost 3.5 years ago, almost 4 years now, I was having a few stomach pains, but not much. And the main part was just my physical appearance. I wasn't growing, my hair was thin, I wasn't gaining weight. So obviously there was something wrong there. And I was having a few pains, but not as many symptoms. All the symptoms I had could have been something else. They're not just Crohn's, but that's how the test came out.
So did you get diagnosed pretty quickly? How did they diagnose you?
So it all started when I was actually at an appointment for my allergies, because I have hay fever and I have a sensitivity to dust, and they just happened to do a blood test and it came back with showing high inflammation and that it was abnormal. So I got referred to a gastro team, and then I had an ultrasound, MRI, stool sample, and and colonoscopy to test. So I had all those in the space of couple of weeks, and then after that, it was a few weeks after that till I found out that I had Crohn's disease. So from doing the blood test in early summer till September, it was a few months, I believe.
Right. Okay. And did they start you? What did they start you on? Which medications did they put you on to start off with?
So to start off with, I was on Modulin.
Oh, how was that?
Well, it was probably one of the hardest things. It's a liquid diet, so I couldn't eat anything for 6 weeks, and it was just these, like, the best way to describe them are like health shakes type thing, like 6 times a day. And it was just this liquid to drink, and it wasn't the nicest thing to drink, but you could make it nicer by mixing in some Nesquik flavors into it. So that added a bit of variety, but it still wasn't great. And then I was also put on azathioprine, which is a pill which I'm still on today, which is 2 tablets a day. Yeah.
So did the Modulin and did that help you to begin with, or did you still have symptoms?
So I was led to believe that it was getting better. I think it was more of like a placebo, but the tests after when the test came back, because I had blood tests and stuff when I was on the Modulin, it hadn't brought the inflammation down. I believe it brought it down slightly, but nowhere near that's needed. So then I was put onto steroids, which I think was a 6 to 8 week course. And then after that, the steroids didn't work. So I was then moved on to infliximab, which is intravenous drug every 8 weeks. I go to hospital, and within the space of an hour or so, it's put into my bloodstream, and I'm still on that today because we believe it's working.
That's fantastic. So what sort of side effects did you have when you first started on the steroids? Those can be quite, it can have some quite nasty side effects. Did you put on weight? Were you eating a lot? Did you get sort of shaky at times? How did you find that?
So I don't think that I had many as far as I can remember. I think I was more just worried about, more thinking about whether it's working, than actually thinking of the side effects. So I can't really remember if there were any side effects at the time. I don't think there's. I was told there were loads that could happen. I think thankfully I didn't have as bad as what they said could happen. So yeah.
How did you find drinking the Modulin at school? Did you explain it to your friends, or did you just sort of say, I'm having a milkshake? How did you go about it? Were you open about it?
So this is the problem, because it was right at the start, around October time of 2016. I didn't really tell anyone. I think I told my closest friends, but I didn't tell anyone, and I had to take 2 drinks in, one to have at break time and one at lunchtime. And in that time, the worst part was lunchtime, first of all, because people were like, why are you just drinking these health shakes the whole time? Are you going on some sort of diet or whatever? And then the other question is, why are you not coming to the lunch hall with us? Because they'd all be like, why are you outside by yourself, not coming in to eat lunch with us? Because I know if I went into that lunch hall, I'd be tempted to eat the food, and then it would be the end of any success shooting Modulin. So it was quite tough, but I don't know how I got through it without telling people, but I wish I did.
And when you started the infusions, was that stressful? It's quite a stressful thought, but was it as bad as you thought it was going to be, or not as bad?
So for me, the thought of needles, people sometimes go, oh, needles must be so scary. And for me, I'm not really scared of them. So the whole thing of having a needle in your hand for a few hours didn't really scare me. But what did scare me were all the side effects that we had to sign a consent form for, which gave so many different things that could go wrong. I can't even name them.
Yeah, it's better not to even look, isn't
Yes.
it?
But thankfully, so far I've been fine. I've not had any side effects from it, and it's been working. So
That's brilliant.
Yeah.
That's the main thing.
Mm-hmm.
So did you see effects straight away, or did it take time for it to kick in with the infliximab?
So I think the first 3 doses are very close together, and I had those before I went on like a school trip with school for 3 weeks. So we rushed those in at the start, and thankfully over the school trip I actually don't remember having any problems, and I felt fine. So I think after those 3 introduction ones, it started to improve. But I think as the first year went on, I started to finally grow, put on weight, my hair got thicker, all the things that weren't happening beforehand.
Your hair's looking good. And what about your diet? Did you have to change your diet at all? Do you find certain foods agree with you, certain foods don't? Things like fried foods, spicy, things like that, or you can eat whatever you want?
So originally when I was brought off the Modulin, I was put on a very specific low residue diet. So I was very gradual back into introducing foods. But what I've been told along the way is just test and see what happens. It's more about, they don't give you a set diet. It's test to see what doesn't really, they have their recommendations of what groups won't work, but for some people, different things don't work. So I found over years that I can't do spicy food, but which is good because I'm not really a fan of much spicy food.
That's lucky.
Yeah. Things with like nuts and seeds, but once again, I don't like that sort of stuff. And like some fiber stuff is difficult to digest.
Like raw fruit and veg, like healthy things, are you able to tolerate like raw fruit and veg or not?
So for fruit and veg, it kind of needs to be cooked. So I have my famous joke, which means that it's healthier for me to be unhealthy.
Yeah, exactly. It's quite tricky, isn't it, that? Because everyone's always telling you eat more raw fruit and veg, and actually that's not good for you. So you've got to do what's good for you. Have your friends and family been supportive of you? Like, when did you start talking about it openly?
So as a whole, my friends and family have been very supportive. Obviously, my family since the start, since I was originally diagnosed. And then I told my closest friends, I think a few weeks when I started on the Modulin. And when I did tell them of what I had, what my diagnosis was, they actually were researching on the bus to school as soon as I had told them what it was, which showed me that they all cared and wanted to make sure they were there for me to spot anything. And once I told more and more people, it became easier. So once I told one, then the second one became that slightly easier, to now where I've just told basically the whole world through this documentary. And that was, by the time I got to that point, very, very easy to do. It was nerve-wracking at the start, but what's come out of that, very happy with the result.
Good for you. Yeah. How do you feel it's affected your life, having Crohn's and then dealing with it and sort of getting through those few years? Has it sort of affected you in any major way or not really?
So I think in terms of affecting my day-to-day life of what I want to do versus what I can do, it's not really affected me that much. In a way that now, at the start when I was on the Modulin and I had to make sure I was like at home, or I had with me enough Modulins, because you have to take them at like a sort of routine. So like every few hours, have a drink. So at the start, that was a bit like annoying with social arrangements, but now, since I've been on infliximab, I would say it's really not stopped me apart from the days when I have to go in. But when I do that, I just go in and I sit there with the infusion doing schoolwork if it's during the school day, or messaging friends or watching Netflix and YouTube. So I don't think it really limits my life anymore much.
That's fantastic. Yeah. Do you think there's a stigma about having inflammatory bowel disease, something like Crohn's and colitis? Do you think there's a stigma attached to it, or you think it's becoming less and less?
So I think it is becoming less and less, the stigma, but I think the stigma has always been that everyone with Crohn's and colitis or some form of IBD sits on the toilet all day long and doesn't leave, and like our best friends with the toilet. When in fact, when we're not having a flare up and all is good, we are actually going to the toilet usually as many times as normal people do. So it's literally, there is that stigma that you're on the toilet, but I think bringing awareness to it through everything that goes on, and especially now, there's a large youth following on social media, loads of kids with IBD now sharing their stories on social media, which is incredible because it's from a young age, people are now learning that it's not a stigma and that it doesn't stop people's lives.
Absolutely. So what tips, what advice would you give to someone else in your position, you know, who's going through this, someone who's just starting out? What would you tell them? What would be your best advice?
So I think my biggest advice is just to people to not be afraid, don't be worried. It does get better. I know at the start it probably is a bit of a whirlwind, but life does get better. And as long as you tell people, it's not going to restrict you. So my biggest recommendation is just to speak out and not try and keep it that secret, because keeping a secret is harder than telling people. So I would just encourage you, wherever you are in your treatment, just to start telling your friends. You don't have to go and post it on Facebook tomorrow. Start telling your closest friends, then tell your whole friend group, and then go further until you feel like every time you tell someone, it's just going to be easier to tell someone, easier to live with. Yeah, that's my biggest advice.
That is great advice. Thank you so much, Matty.
Thank you.
I'm now going to go through some of the questions that we've had. So the first one being, hang on, let me just get some of the questions. So first of all, let me say hi to Dr. Mann. And can we, Matty, can you unmute him, Dr. Mann, so that we can have a little chat?
Dr. Mann, you should be asked to unmute. Yeah.
Hi, Dr. Mann. Hi. First of all, hi. Good evening. First of all, Mazel Tov on your daughter Eliana's wedding.
Thank you.
You've been very busy.
We just finished our week last night.
Oh, fantastic! You must be quite tired. I really appreciate you joining us. It's really nice of you. I've had
7 days. It's a pleasure to join you.
Oh, thank you. I've had a question for you. I hope you're going to be able to answer this. Have you seen a high incidence of IBD patients coming into hospital with COVID?
It's a good question. The answer is no. We don't seem to. I mean, but there's two. The answer to that I'll do two ways. One is personal experience, and one is from the literature, from China and Italy and Europe. Certainly from the literature, there's no evidence that IBD patients pose a particular higher risk of COVID than non-IBD patients. And secondly, in my own personal experience, which was looking after COVID patients from the end of March to the end of May, beginning of June, there was no particular increase in incidence. And I think generally the consensus is that having IBD per se doesn't increase the risk of COVID. The next point about IBD and COVID is whether the drugs that patients are on may increase the risk, because as you probably know, many of the medications are potentially immunosuppressing. Apart from high-dose steroids, it seems that the other drugs do not seem to increase the risk, nor do they increase the risk of complications if you were to catch COVID. So high-dose steroids is our biggest concern in our patients, rather than azathioprine or infliximab, as Matty was referring to.
Fantastic. Okay, thank you. Sorry, I'm just trying to access some more questions.
Whilst you're doing that, I'll just add that although my drugs aren't a bigger risk to COVID, I have been told by the NHS, I was told by the NHS to shield for the last 3 months, but that's now officially over, because they thought at the beginning, they panicked that every drug which is immunosuppressant would increase your chance of getting it badly. I've got the same chance of getting it as everyone else. It's just, and I've got age on my side, so I'm not sure if we do have another peak if I'm going to have to shield again, because they are looking into that about who exactly is going to shield.
Yeah, actually, if I can just comment on that, Matty, one of the most common inquiries that we were getting to our department during March and April, when all this kicked off, was about the letters that patients were sent by NHS England, I think it was, or texts telling people to shield and self-isolate, which was based on the fact that you're just on a particular drug, not about you as an individual and your own individual risk. We, in the world of gastroenterology and IBD, came up with guidelines. And apart from patients who are on high-dose steroids or people with disease activity, plus the other usual risk factors, which was about age and comorbidities, we considered patients on azathioprine or infliximab, if they were stable and not having disease activity or recently started, as moderate risk. And moderate risk means just pay more careful attention to social distancing and hand washing and the not touching your hands and not touching your face, rather than social isolation. So there was a discrepancy between the blanket email that went out to patients and the guidelines that we in our societies were recommending. So it's good that you brought that to our attention. We had a few queries, and I think Devora sent me a few queries along those lines as well. Yeah.
Another question for you, Dr. Mann. Is Modulin the same as Ensure Plus?
Pretty much. They both do the job. In terms of that, I mean, the exact ingredients, I can't exactly be sure, but they're both polymeric diets, which means that they're pre-digested, complete nutritious protein, carbohydrate, and fat contents that are pre-digested. And they're both made by two different companies. Modulin's a Nestle company, and Ensure Plus is made by, can't quite remember, Fresenius, I think. The actual ingredients are very similar, and they both work in a similar way with an anti-inflammatory component in the intestine, and both have about an 80% response rate in Crohn's disease, for example. Particularly in growing children and adolescents, it's used a lot because we try and avoid steroids in that particular population, because steroids can potentially stunt growth. And in adults, we would very rarely use Modulin or Ensures, but in kids and adolescents, it's very, very commonly used as a first line for Crohn's rather than steroids for that reason. And they're very, very similar. I don't think they're identical, but they're very similar.
Thank you so much. Next one's for Matty. Matty, please could you share details of the online teen support groups that you mentioned? Thanks.
Okay, so This is what actually I found recently, all these support groups, because I set up an Instagram page called @myIBDLife. So I'm sharing on there a lot of things to help young people with Crohn's and events. And we have also brought on, I've also contacted now, we've got at the kid with a bag on Instagram, Ollie K. Also at Crohn's_colitis_warrior, I think. I can find a list and maybe we can post it on the Jewish Digest Facebook page. But I don't know all of them off the top of my head, but there are all these Instagram accounts run by people around my age, sharing what they're doing with their Crohn's, how it's not stopping them, that sort of thing.
Yeah, and just to add to that, Matty, we were discussing about setting something up on the Jewish Digest, like a young Jewish Digest for teenagers. So that's hopefully something that we're going to be setting up together. So we'll just keep an eye out on the Jewish Digest page, social media, website, and it will be on there. The next question is, just lost this question, hang on. Why is IBD so prevalent in the Jewish community, Dr. Mann?
Yeah, I've been involved with colleagues looking at the genetics of IBD, and we got a publication in something called a high impact journal called Nature Genetics. It's a good question. There are some genetic predisposing factors. It's not about, schmaltz herring and cholent, it's about genes. And the incidence is about 4 times higher in Ashkenazi Jews than it is in the non-Jewish population, or the Sephardi population for that matter. And the prevalence means that the number of people in the population who have it is highest in Israel and in New York, for the very reason that there's so many Jews in those two places. So there are some genetics that suggest that there's a predisposing genetic risk factor, and presumably there must be some environmental component too, but which we don't really fully understand. The thing about the genetics in Jewish people is that the risk of other family members having Crohn's or colitis is higher than in the non-Jewish population. So the figures are something like 1 in 7 chance of a family member having it if you've got it in the Jewish population versus about 1 in 10 in the non-Jewish population. So it's not purely genetics. There are obviously other factors that contribute. So for example, in twin studies, you can have identical twins, one will get it and one won't get it, but it's quite a much higher percentage concordance, which means if one's got UC, the other one will get UC, or if one's got Crohn's, the other one will get Crohn's. But within family clusters, particularly, there's some large Ashkenazi families, perhaps in Stamford Hill, where there's many patients affected within one family across different generations and cousins and second cousins. Some have got UC and some have got Crohn's. So, work in progress, but certainly a lot of genetics involved in this question.
Thank you so much. Does warm climate make a difference to Crohn's? I think yes. I think we should all be moving to Miami.
There are many environmental factors that are thought to have a part to play in the development of Crohn's and colitis, whether it's to do with diet, temperate climate, exposure to, there was exposure to hygiene, and there was a theory about outside toilets versus inside toilets back in the day when everyone, not everyone had an inside loo. And all these environmental things are speculative rather than proven scientific associations. So, you can have Crohn's and colitis across the world, some in more temperate climates than others. So I think, if anything, it's probably an irrelevance. And it's interesting. I'm not quite sure why that question was asked. I'm not whether there's a particular, whether there was a drive for that question, or it was just purely curiosity, because I don't think there's much science behind a link between that and IBD.
Okay. Next question again, Dr. Mann. If one has active disease, what precautions should one take in relation to COVID?
Okay, well, that's obviously a topical question. We consider patients who have got moderate to severe disease activity in both UC and Crohn's as being a higher risk of complications and a higher risk of complications from COVID. And that's because the COVID virus itself enters through particular receptors in the gut or in the lungs, in the respiratory tract. And when the gut is diseased, you're more susceptible to having transmission through the gut route. So the precautions, if you've got disease activity, is to actually shield and self-isolate. If you've got mild symptoms, you can just have stringent social distancing, as it were, i.e. face masks, hand washing, don't touch your eyes, nose and mouth, and 2 meters social distancing. But if you've actually got moderate to severe disease activity, or certainly if your symptoms are not under control, you ought to really be socially isolated and quarantined until the disease is under control, or until your dose of steroids is less than 20 milligrams of prednisolone.
Okay, yeah, we've had a few queries about this, about people who are on immune suppressants and they're not sure whether they should be socializing. Can we just sort of chat about that for just briefly? I know it's difficult to, everyone's got different circumstances, but if somebody's on immune suppressants, their disease is under control, they're not on steroids at the moment, would you say that's, you know, okay for them to socialize indoors if they're wearing a mask?
Yeah, I think if you know, in let's say the IBD world, which is what we're talking about, as opposed to people on immunosuppression for other conditions, because I'm not going to talk about respiratory conditions which predispose patients to more complications anyway. But let's say in the world of IBD, if patients are well maintained on their immunosuppression, whether it's azathioprine or 6-mercaptopurine or infliximab or vedolizumab, they would be considered moderate risk, which is essentially, as I said before, is stringent social distancing rather than quarantine and isolation. And that means that they follow the government guidelines. They, you know, 2 meters, wear a mask and frequent hand washing, and, you know, pay due care and attention. It's not about hiding in your bedroom during the whole course of this COVID thing. More interesting question along those lines is what I've just answered is a more general response. I've had specific queries from teachers because as schools start to go back, some staff are on, you know, drugs like infliximab, let's say, or azathioprine, and they want to know, you know, in a situation where they can't socially distance, like a school, what is the risk? And it's very hard to give a very specific answer to that because we don't know yet what the outcome is from schools. So, you know, I think they are potentially more vulnerable, but, and if they can't socially distance, it must be, you know, an anxiety generating for that individual. If you can socially distance and get access to frequent hand washing or sanitizer, then I think you're okay. I think it's safe. There's not been any evidence of an increased risk of complications in that population. We haven't had the schools going back yet. And as far as I know, in other countries where schools have restarted, we're not seeing a peak in that subpopulation either.
Okay, that's great. Question for Matty. How were you diagnosed and what symptoms do you find most annoying? So just if you could just briefly go over for those people who weren't here when you discussed that.
So I was diagnosed out of chance by going to I went to an appointment for my allergies because I have hay fever and I'm sensitive to dust. And they happened to do a blood test which came back abnormally with high inflammation. So I got passed on to a gastro team who then conducted colonoscopy, MRI, ultrasound, and stool sample to test for IBD, and it came back that I had Crohn's, and my symptoms. So my symptoms before I was diagnosed were a few stomach pains, and my hair was thinning, I wasn't growing, I wasn't gaining weight. And this is when I was 13, when you're supposed to be changing physically. But nowadays, symptoms-wise, every so often I'll have a flare-up. I want to say once every month / every other month, and those symptoms will be a day of just probably maybe stomach pains or needing to rush to the toilet. It can be annoying at times, but I've kind of got used to it, so I don't really find it annoying anymore.
Okay, thank you, Matty. Question, I think it says for me, is Jewish Digest a Jewish support group for people with Crohn's or IBD? It's the first we've heard of it. Yeah, so we're a charity, we're quite new, a few years old. We're just a group of volunteers who we run events usually. Now this is why we're doing an online event, but usually we have events in different locations with different IBD professionals. And we also have a buddy system whereby we introduce people who are in similar stages of their IBD, so they can chat together. Have a look at www.jewishdigest.org, or on social media, we're Jewish Digest, so have a look at that. Next question is, what do you think about hyperbaric oxygen therapy? That would be for Dr. Mann.
Matt, do you want to answer that one, Matt?
I'm not quite sure.
Well, you've been so marvellous and articulate with all your answers. I'm trying to shirk that question because I don't know all that much about it. It's one of the potential treatments in perianal Crohn's disease. So in other words, some patients have a lot of disease activity around the bottom end of their rectum and around their bottom, with fistulas and strictures and skin tags. There was some studies about a decade ago looking at hyperbaric oxygen, which is basically meaning you're in an oxygen chamber breathing in 100% oxygen compared to 21% oxygen, which is what we breathe on a daily basis in the air. And the studies, I think, were favourable in perianal Crohn's disease. I'm not sure about colitis. I'm sure there were studies, and I suspect that the results weren't favourable because I'm not sure about it. And the problem is with the perianal Crohn's disease group of patients is hyperbaric oxygen chambers across the UK are few and far between, very difficult to access. So it's not really an established therapy. If somebody really wants to know a bit more about it, they should PM me perhaps later, and I can look up if you want, because I don't really know any more details than what I've just shared with you.
Okay, so if you just email info@jewishdigest.org, you can get in touch with Dr. Mann through us, and hopefully he can explain further. Where is Dr. Mann based? As he said, schools aren't yet open. He's in the UK. I guess some schools aren't, not all classes have gone back. So I guess that's what you meant by schools aren't open. They're not open properly.
Yeah, some teachers are still at home, and so not everyone's back.
It's not back to normal. The next question was for Matty. Do you have any tips about the liquid diet?
The liquid diet. Okay,
I know you don't want to remember.
No. I'm just trying to think back to 3.5 years ago. Tips about, okay, so I think a tip would be to just don't tempt yourself. So don't go places where there's going to be the smell of hot food. So I kept out the kitchen in my house where I could. Like I said, I didn't go into the lunch hall at school because I knew even if I went in there and sat there and talked to my friends while they were eating, I would probably get tempted. Yes, it's 6 weeks, but in a large mix of things, 90% of the time it works to help you. I was just that small 1 in 10. So for relief, in the short term, it's hard, but in the long term, it will help you. So I would say just fight through it. Don't tempt yourself. Yeah.
Thank you, Matty. Another question for Dr. Mann. Is there a decrease in patients requiring surgery as a result of increasing use of biologics, or is it too early to tell?
No, it's a good question. I mean, it's not really that early to tell. Infliximab first came out in 1999 for Crohn's and in 2001 for colitis. So it's 30 years nearly, actually. 1990 was, 99, it's about 20 years already. So our surgeons are getting far less work than they ever used to. And that's having an impact on training the next generation of surgeons, in fact. So it is a good question. The drugs and the choice of drugs available and the impact of drugs on modifying disease has been so great that the surgeons don't get that much opportunity to operate on patients with IBD. And this is a big issue, so much so that the recommendations really are that not every hospital does operations anymore, and the patients who need surgery are referred to central locations. So there's what's called like a hub and spoke type of service, a bit like bowel cancer work. They're all centralized. And for example, if you have a colectomy for colitis and you need a pouch, very few surgeons are doing pouch work in district hospitals. So we send them to a central place, let's say in London, if you're in London, St. Mark's Hospital or maybe University College. A lot of the Crohn's patients will have their surgery centralized unless it's very straightforward routine surgery. So I think the biologics have had an impact, and the number of cases has gone down. Actually, it's a very good question.
Okay, thank you. Matty, do you want to tell us a bit more about what your future projects are looking like and what you're planning? I understand you're doing another documentary or another video for people with Crohn's and colitis.
Yes, so I've decided that after making my documentary and seeing the success of it, last time I checked cross-platform, it's now over 1,500 views, but I've not added it up recently. So it's probably a bit more now. So what I've decided to do next is I'm going to be filming either a series or a long-form documentary which goes around and films many different young people's, or just in general people's, experiences with IBD and how it's not affected their life. I'm currently in the pre-production stage of it, and we're currently looking for people who want to be in it. So if you know anyone with IBD who actually would like to talk on camera, you can go to mattyfisher.co.uk/myibdlife, and there's a form to fill in to be in the documentary. Yeah, that's my upcoming project. I'm going to continue posting on my Instagram to keep sharing all that stuff. So contact me if you'd like to share your story.
Fantastic. A couple more questions just come through. Matty, do you feel like you have sufficient access to information that you need to manage your disease?
That's an interesting one. By information, if it's about dealing in everyday life with the disease, about what to do, I think some of it you just have to learn, because everyone's quite different with how they experience things and symptoms. So I see it as you just kind of not learn on the job, but learn whilst it's happening, and then you get used to it. In terms of like diet, they do have like diet recommendations, but once again, it's also about trial and error at the start to figure out what actually works for you and what doesn't. So yeah, I think there is enough information to inform you on the general basis, but then the detailed stuff you'll only really know about yourself from your own experience, because most people have slightly different experiences.
Very true. Dr. Mann, one for you, if you're still there. Given the current lower levels of coronavirus around, would it still be concerning to start a course of steroids for a flare-up, or should this be avoided?
Well, okay. We're still concerned. I mean, there's a low level in the country, there's a low level in London, but it's not gone away yet. And one of the highest risks for transmission is the asymptomatic transmission. So just because you haven't got a cough or a fever or anosmia doesn't mean to say that you're not sort of sitting talking to somebody on the bus or the train or at work who's an asymptomatic carrier. So we are very conscious of our patients' disease control, and we do attempt not to use steroids unless we have to. So it's a balance between the risk versus the benefit. And if they do need to go on steroids, we try and wean them off in a much quicker way than we would traditionally. So normally we would put them on an 8-week course of steroids, weaning down from 30 or 40 milligrams over 8 weeks. We do try and expedite that under the circumstances of the current COVID situation. So we're trying to get them down, weekly instead of fortnightly, or over 6 weeks instead of 8 weeks. And as soon as we can get them down to 20 milligrams or below, they move into the safe zone and they can come out of isolation.
Okay.
I've actually had that conversation yesterday. I've got a patient on the ward at the moment. I'm doing, I work on the wards at my local hospital, and I had a patient with IBD who was bad enough to be hospitalized and need IV steroids. And we had the same conversation about trying to whittle down the dose as quickly as possible.
Okay. What happens if you miss the infliximab one time and there is a delay in getting an appointment in clinic?
Well, one of the, in terms of the IBD service, one of the things that we're very much trying to promote is patients' well-being, and all the units across the country have been striving to maintain infusion service. So anybody that's been getting either their injections subcutaneously or in the day treatment unit for their IV infusions, we've been encouraging them to try and stick to the 8-weekly cycles or whatever cycle of treatment that they're on. If you miss a dose, a week, 2 or 3 weeks, I suspect that it won't make any difference. Although some people do start to get symptom recurrence just before their 8-weekly dose is due. But I believe that most units are encouraging everybody to stick to their pre-COVID regime and not to sort of fall foul of slipping, because the worst thing that you can have is a flare-up of their disease because you're trying to be clever and not come to the hospital. And if you've got a flare-up of the disease, you then become a high-risk patient, and then you've got more risk of COVID and its complications.
I can also add to that. So I've been having my infliximab every 8 weeks still during the COVID situation. And I've had to sometimes change the date of an appointment by like a week or so. So either it was a week earlier or a week or so later due to either being away or stuff. And that's not really a problem. It's not really affected the treatment. The one thing I would say is exactly what Dr. Mann said, is that there is a tendency that you usually have like a small flare up like right before the 8-week dosage. So if there is a delay and you've had to extend it another week, there's a chance you probably will could have symptoms in that 8th till 9th week before your next dose.
Thank you, Matty. Another question for Dr. Mann. I'm 41 years old and was diagnosed with Crohn's approximately 7 years ago. Infliximab and Stelara don't seem to be keeping the disease under control. Do you have any suggestion or recommendation for an alternative medication?
I'm only going to give you a general answer to that because obviously everybody's Crohn's disease is different. It depends on how it's affecting you symptomatically. It depends which part of your gut is affected, if it's small bowel, large bowel, or perianal. But there are other drugs available, as I'm sure many of you are aware. So you've tried infliximab and then you've tried Stelara. So the discussion would really be centered on whether we should move on to third-line therapy or move into surgery. And that depends on where your disease is, whether surgery is a potentially useful option or not. There are other drugs, and you've obviously not mentioned vedolizumab, which is Entyvio is the other one, vedolizumab. That's available for Crohn's disease if you've not been on it already. And then you're looking at trial drugs, clinical trials. Those are the 3 that are currently licensed for Crohn's disease. So you've tried 2 of them, and there's a third one or surgery. And then I suppose the other thing to think about is if it's small bowel disease, the enteral regime like Matty's been on, Modulin or the like, and we do sometimes do that as a salvage for small bowel Crohn's. It doesn't work for colonic or perianal.
Couple more questions and then I think we'll wrap up. One more for Matty and one more for Dr. Mann. Matty, did you ever get help from KICRA, the Crohn's in Childhood Research Association?
I've actually not really ever heard of them, so I can't really speak about experience with them. I just had loads of assistance from the doctors and nurses in the pediatric department at the Royal Free.
Okay. Dr. Mann, my wife may have to undergo biologic therapy for her Crohn's. I understand that this is quite aggressive. Is there an alternative? She's been in remission for the past few months.
If she's in remission, I'm not quite sure what the plan is. Generally, patients would escalate onto biologics if they have failed to respond to standard therapies or they're still on recurrent courses of steroids in spite of standard immunomodulators such as azathioprine or mercaptopurine or methotrexate. So I don't consider biologics as aggressive therapy. I would consider that as very useful, potentially life-changing treatment that can transform a patient from being unwell with a poor quality of life on and off steroids to somebody who can move on in life a bit like Matty and get on and go back to work or school and function normally. So if your wife is on and off steroids, that has far worse side effects and outcomes than a year or however long is required for something like infliximab or vedolizumab. The safety profile of those drugs is actually very good indeed, and you will be counseled about those drugs presumably by your IBD team. I wouldn't look at it as aggressive. I would look at it as actually something that can transform somebody who's unwell to somebody who's well.
Thank you so much, Dr. Mann. Can I ask if anybody wants another event like this, what you would like us to discuss and who you'd like to have on here? If you have any sort of suggestions, please let us know in the chat, or you can email at info@jewishdigest.org. Thank you so much, all of you, for joining. It's really kind of you, Dr. Mann, to spend some time with us and to answer all the questions. Thank you. And thank you very much, Matty. You're a real inspiration. Keep spreading awareness, and it's really important for everyone to know that once they share their story, it actually becomes a lot easier. And yeah, we really wish you good luck in all that you do, and keep well. Thank you, everyone. Good night.
Thank you, everyone, for coming.
Thank you, Devara. Thank you, Matty.